So I've been at the ESMO meeting in Munich, and I've been following the genitourinary studies. That's what I do. There have been a number of, well, first of all, I don't think there have been any big surprises, but there have been some really important practice-affirming and maybe soon to be practice-changing data. In terms of the practice-affirming data, I would highlight one study which I think is really important, and this is another analysis of the STAMPEDE trial. This is about the use of Abiraterone in men, specifically the subgroup of men with metastatic disease. Now, we saw those data last year. These are not new. And we know from STAMPEDE that men with metastatic disease have a significant survival benefit by adding in Abiraterone early. That, of course, was one of two trials. There was another trial called LATITUDE, which was exploring the role of Abiraterone, but specifically in a group of men who were defined as having high-risk metastatic disease. Okay, so it wasn't the whole group, and so. Indeed, that LATITUDE study was the study on which the marketing authorization was based. So in other words, the marketing authorization currently stands for those patients with high risk metastatic disease. So the subgroup analysis we've just seen was actually the real question was, does the low risk group also benefit from Abiraterone? And the answer is clearly yes. There's this independently applied subgroup analysis that there's a statistically significant survival gain, and indeed all the other efficacy endpoints were also positive for that low risk group of patients. So that's practice affirming, because of course having the two studies with the slightly different populations just left a question as to whether it was the correct thing to be doing, to be giving Abiraterone to all men with metastatic disease, and indeed it is. In terms of practice-changing studies, there's also another new analysis from STAMPEDE, and this is from the arm for patients with metastatic disease who are starting androgen deprivation therapy for the first time, and whether or not adding in radiotherapy to the primary tumour, that is radiotherapy to the prostate, could improve survival times. Now, this is an interesting concept, because of course the general notion with cancer therapy is that there's only the value of treating the primary is to prevent it from spreading, and therefore once it's already spread, the assumption is that there would be no benefit in treating the primary. But of course we know, particularly from kidney cancer, that there for many years has been evidence that if you remove the primary tumour, then even in the presence of metastatic disease, survival outcomes can improve. Not a cure, it's a palliative treatment still. And so this is so in this study, the use of radiotherapy, what it showed was that in the whole group, it didn't improve survival, although there was a trend towards that, and indeed it did improve failure-free survival. But if we look at the subgroup of men with low volume disease, and this is defined as in the charted trial, that is bone-only disease, fewer than 4 metastases, and excluding the axial skeleton. And what it showed in that subgroup was that there was a statistically significant survival advantage by giving radiotherapy to the prostate. Now, it's a subgroup analysis, but it was a pre-planned subgroup analysis, and I think it's therefore potentially practice-changing for some men. Of course, this is in isolation, largely in isolation of other therapies such as Abiraterone and docetaxel. So how this would fit in for all patients is less clear, but I think it does now present another life-prolonging option for some men with low-volume metastatic disease.